Yeah. Yeah, I didn't. No, yeah. All right. I mean, I haven't done this conversation for tonight. Let's see. Yeah. So, 4.5 years. That's backward. Two.
Testing, testing.
Okay, welcome everybody this evening. We'll get started. Here's your CME code. This one next. Thank you. And just want to quick highlight the upcoming faculty meetings and then upcoming grand rounds in early December, Dr. Gropler and Dr. Vidnathan. And then some faculty meeting, and then already approaching us are the holidays, hard to believe. But now we will pass things over to Dr. Lampert to introduce our speaker today. Thank you.
Thanks, Catherine. I'm so pleased to introduce Dr. Dermot Phelan. Dr. Phelan got his MD PhD at the University College of Dublin in Ireland and did a cardiology fellowship in Galway, and then came to the United States to be at Cleveland Clinic for imaging and stayed and joined the faculty there until he moved to Atrium Health in 2020. There, he's the Gregg Endowed Chair for Cardiovascular Medicine, and he directs the cardiovascular imaging, sports cardiology, and co-directs the HCM centers. In the sports world, he has chaired the ACC Care of the Athlete Heart meeting, and also chairs the Cardiology Advisory Task Force for the NFL, and serves in similar roles for the NBA and Major League Baseball. He's also active in the American Society of Echocardiography, where he is the incoming chair of the program for the upcoming meeting. He's speaking to us today on aortic valve and aortic disease in athletes. I'm so pleased to welcome Dr. Phelan.
Thank you, Rachel, and thanks everyone for being here today. Real pleasure and real honor to be able to come to Yale and give grand rounds. I had a phenomenal day today, meeting so many people here, just so welcoming, and it's an amazing program. So thank you everyone for joining. So we're going to talk about managing athletes with bicuspid aortic valve disease and aortopathy, and I'm going to begin with a little pop quiz. What do these two individuals have in common? Or maybe, does anyone know who these two individuals are? I'm sure everyone knows Arnie there. So Arnold actually had a bicuspid valve and had that replaced. Anyone know who the other gentleman is? You all do. He's actually Leonardo da Vinci. And Leonardo da Vinci actually is credited with being the first person to actually animate a bicuspid aortic valve. So just a little trivia for you going forward. So we all know the normal aortic valve is actually formed by the 9th week of fetal life and normally has 3 leaflets. Bicuspid valve, by its name, has 2 leaflets. It's the most common congenital abnormality, 0.5 to 2%, with a 3-to-1 male to female ratio. And it is associated with various different lesions. And this is really what we're going to be focusing our talk on today, looking at aortic regurgitation, aortic stenosis, and ascending aortic dilation and aneurysm, with a particular slant on how we deal with this in the athletic population. For all of us here, general cardiologists, pediatric cardiologists, this comes up frequently. You know, I have a bicuspid valve, I have some associated pathology, how much exercise can I do? And so this can be a challenging clinical conundrum. There are other associated pathologies that we're not going to talk about today. So really the origin of this Grand Rounds invite from Rachel was based on a patient. There was a patient that we shared with a bicuspid valve with aortic regurgitation And how we manage that patient kind of was the genesis of why I'm here today. This was a 23-year-old, 6'4", Division I rower who had known that he had a bicuspid aortic valve since the age of 14. He did not have any aortopathy and only had mild aortic regurgitation on yearly follow-up, but he comes back and on his follow-up echo, it looks like he's had a significant increase in size of the LV, and he looks like he now has significant aortic regurgitation. And here is his images. You can see he's a Sivers type 0, so there's no raphe there. It's kind of a vertical commissure, and we can see that there's certainly prolapse with significant aortic regurgitation with diastolic flow reversal. So it looks like it's pretty significant aortic regurgitation. And appropriately, he goes on to get an MRI. And the MRI shows that his left ventricular end diastolic index volume is 143 mils per meter squared. His right ventricular end diastolic volume is 110. He doesn't have any scar, but his regurgitant fraction is 34%. So he actually is not from the US, and his cardiologist, who he'd been followed with in Europe, just advised him to stop exercising, referred him for surgery, and he presented for a second opinion. So what do we want to think about with a young elite athlete who's asymptomatic that has significant aortic regurgitation? Well, first of all, what are his indication for surgery? And we'll look at this in a moment. To what degree can we explain his LV remodeling based on his athletic profile? And what is the risk of continued participation for this particular individual? So if we take a step back and we look at how this is relevant to sports cardiology in the athletic population, really, when we look at the different stages of aortic regurgitation, we're not talking about stage A. I mean, they can do whatever they want. Stage D, when they're symptomatic with severe aortic regurgitation, they need to be fixed. So we're not talking about those population. We're really talking about stage C, the asymptomatic severe aortic regurgitation, and maybe into stage B, where they're getting progressively towards that end of the spectrum. And this is relevant because lots of recent data is showing that we should really be operating earlier on a lot of these individuals. And the guidelines are going towards earlier operations. And we can see, based on the guidelines, if we look at asymptomatic stage C here, there's a number of reasons why we will operate on these. And they're largely based on either significant LV dilation or progressive LV dilation, or even a low ejection fraction. And yet we know for athletes that we're going to see significant LV dilation. And in some elite athletes, we may see some lower normal ejection fraction. So this is where the conundrum is. And these data sets that guide these recommendations are often based on older data sets with low numbers of patients, and they're older population. These are generally not an athletic population. So this is relevant because athletes, as we know, develop physiologic changes in the heart. This can be either electrical changes on the ECG, or more relevant to the discussion today, these are functional and morphologic changes. Now, if we kind of go back to the basics of exercise physiology, what do we need to do when we exercise? What's the cardiovascular system doing? We're trying to get oxygenated blood to the working muscles. And so in order to be able to be more fit and do more exercise, we need to be able to get more oxygen to those working muscles. Now, we do that by increasing our cardiac output, but our heart rate is fixed. We can't really change our heart rate, but we can change our stroke volume. So we can increase the size of the ventricles. And this happens pretty quickly. So this was a study looking at 12 sedentary young individuals that were trained to compete in a marathon. And you can see that even after a few months of time, their LV is increasing in size and their RV is increasing in size. And then sometimes this can be very dramatic. So what are the factors we need to think about when we've got an individual who says they're an athlete and they've got aortic regurgitation? What are the things that are going to influence the size of these changes? Well, one, it'll depend on the sport type. It'll also depend on the size of the athlete, their gender, and their age. And particularly when it comes to sports type, different types of sports have very different physiologic stresses on the heart. And so when we think about pure endurance exercise, this is really similar to the stress of aortic regurgitation. This is really a volume challenge on all 4 chambers of the heart. So we should see all 4 chambers of the heart getting bigger. Strength training is different. Strength training is primarily an afterload effect. It's almost like aortic stenosis. It's primarily affecting the LV. And then when you get athletes who are mixed, like rowers, we get the most dramatic effects. So this is data from Italian Olympic athletes looking at in the blue, the relative impact on LV cavity size and wall thickness. And we can see rowing, like our athlete, is really up there as one of the most dramatic effects on the size of the LV. As I said, we have to remember size of the athlete, and this is probably most eloquently illustrated in NBA athletes, where we've got such a big range of sizes in these athletes. And so when we look at as athletes get taller, their LV gets bigger. And so it does track, and our athlete is here at 6'4", about 195, and his LV is somewhere up here. But again, he's not a basketball player, he's a rower, which is a very different effect. So what would we expect for a rower in terms of size of the LV cavity? Well, this was a question we asked when we were doing the document. There was a lot of discussion. We did the ASE guidelines for competitive athletes evaluation. What should we put in as the upper limit of normal for LV cavity size for echocardiography? And the reality is that the data is a little bit all over the map, because you've got so many different sports, and really our recommendation was to not actually use a cutoff to define what's abnormal in athletes, because that range is so different there. And really, we should try and use gender and sport-specific normative data. But echo does have some limitations. Even though I'm an echo guy, echo does have limitations. And MRI is probably a better way to assess volumes. And there is data looking at upper limits of normal in MRI. And so this is a meta-analysis looking at 27 studies in almost 1,000 athletes. And we can see the upper limit of normal here for an index LV volume is 122. Our athlete was 143. And again, when it's a mixed sport, as he is doing, we should see changes on all 4 ventricles. The RV is usually a little bit bigger here, so the upper limit of normal being 130, his RV is 110. So it's clear that we can say that this is LV dilation is not all related to a sports participation, right? We shouldn't see LV isolated as big as this compared to the RV. The big question is, how much is his sport participation contributing to the overall size of his LV cavity? And I think this is best illustrated with a different case. This was an Ironman that I looked after with a bicuspid valve and moderate to severe aortic regurgitation. And when I saw him in January, his LV volume index was 121. His LV end diastolic dimension was 63. When I saw him in August, it's gone up to 73. And so his echo looked very different when I saw him in August. I actually ended up repeating the MRI, and the MRI showed that his LV is now 147. Now, what's the difference? Has this guy gotten much worse? Well, actually, August was just before Kona. He was an Ironman. He had just qualified to the World Championship of Kona. And after my consultation, he was getting on an airplane to fly to Hawaii to participate in the World Champion Ironman. So he had dramatically upped his training to get ready for that. Now, he naturally stopped training after Kona, and he came back and we repeated it a few months later, and his LV has gone back down into normal range. So our training can significantly impact the degree of LV and RV dilation. So what is his indication for surgery, we asked? Well, he falls below surgical thresholds as he is. What degree can his training impact the degree of LV remodeling? Well, it certainly can, but until we actually detrain him, we don't know how much of this is related to his LV as RV. But also then the other question is, what's his risk of continuing participating, right? So when we're doing shared decision-making, we're talking about these things with athletes, we have to understand what's his risk of continuing to play. And so always we want to think about first, well, could you die? You know, if you continue to play, you're going to die. If we look at all the data sets we have in young athletes who have died, these are probably the 2 biggest data sets. Here looking at athletes from 1980 to 2011. This was a 20-year study looking at NCAA athletes. And in neither of these data sets was there any athlete who died from pure aortic regurgitation. And so we have got no data that shows that they're at risk of dying. Well, what about disease progression then? Well, generally aortic regurgitation is actually very well tolerated in athletes. You know, when they're exercising, diastole shortens and actually the amount of aortic regurgitation goes down. So they generally tolerate it well, and there isn't any data to suggest that continuing to participate is going to accelerate the disease process. And John and I were talking about this today. We have to balance the risk of watchful waiting versus the risk of sending them to surgery. I mean, they're really, for a young athlete who's 24, who's got severe aortic regurgitation, there's lots of different options depending on what surgeon you go to. Someone will put in mechanical valve. They may try to repair the valve, the Osaki procedure, Ross procedure. When you've got all of these options, it means none of them are very good. And so we've gotten to a point where we're going to send someone to surgery where we don't have really clear, good outcomes. So how do we assess this young rower? So essentially, I think the first thing is to consider it in the size of the LV in the context of his size and sport. The second is we got to prove that he is truly asymptomatic. And so he actually had a stress test on here where he got 23 mets. We did a CPET where he got to 62 mils per kg per minute. So this guy is an elite athlete. I mean, he can do, he had absolutely no abnormality. So he is truly asymptomatic. We then need to prove that his cardiac function is truly normal. And so I always check a BNP in these individuals. I want to look at how the LV recruits with exercise. And there's some data to suggest that global longitudinal strain will track with LV remodeling as well. So we will look at that. Ideally, I very rarely detrain any athletes. I never certainly do it for HCM or any of those indications, but this is one indication where actually I think it's useful. If you can get someone to detrain for a period of time and you see the LV, all the chambers come down in size, sometimes they go well below any surgical threshold and everyone feels a little bit better about it. But he had 1 year left. He wanted to play for 1 year. So we did share decision making and he continued to participate. And these are the guidelines. I'm not going to go and read through these. The ESC have different guidelines, the AHA, but essentially they say a similar thing. So long as the patient can do everything as a normal stress test, and there should be good to go. So what happened with him? He completed his final year rowing. He took a 3-month break and went back to Europe. I didn't actually get the images of his echo, but remember his LV end diastolic dimension was 66. LV end systolic dimension was 49. And after those 3 months of detraining, at least on the echo report that they got, both LV end diastolic and systolic dimensions dramatically came down. So again, he was well below what would be indicated for surgery. I think in this case, he had a good, happy outcome. I'm going to just touch on one other point. This was a different case. This was another hockey player, a hockey player, I should say. He had an incidental note of severe AR with LV dilation during his freshman intake. And he was advised similarly to stop exercising and referred for surgery. Went through a very similar process with him. I cleared him and monitored him for 8 years. He had a very happy college career. Played for 4 years. After the 4 years, he got into business. And he basically stopped exercising. And he continued to come down and be monitored by me. And towards the end, he started to feel he was developing some symptoms. I monitored their VO2 max, and it was quite a dramatic drop in his VO2 max here. And what the point I'm making here is before I ended up sending him for surgery, before surgery, his LV end diastolic dimension was 6 centimeters. Remember, he had already stopped training for a number of years, but after surgery, it had come down to 4.7 centimeters, and that was just 4 months later. So these athletes have very compliant ventricles. They can tolerate this amount of aortic regurgitation very well, and they generally will do very well. Sometimes we do have to operate on them, obviously, but they often will recover very well from that perspective. So I've kind of already said these key points, well tolerated. I think if they're stage C or B with severe LV dilation, we want to make sure they're truly asymptomatic, prove they have normal function. consider the impact of the sport and training they have, and don't commit to surgery on size alone. I think that's important. If they're continuing to train, don't commit to surgery on size alone. Wait until they've detrained and consider the risks and problems with surgery when you send them. Now, on the other side of the coin is aortic stenosis, and this is a very different story. And so this is, we've kind of started on a case-based team, and I'll continue on one. This was a professional, very well-known professional hockey player. He had known bicuspid aortic valve, followed for many years, transfers to a new team, and they do their assessment, and they're very nervous and refer him for a second opinion. And you can see, I don't have my glasses on here, but he's got significant gradients there. And so they actually have been doing stress tests and echo on him for many years. This was in 2006. And you can see that his METs were very high over time. They dropped down. And then by 2020, his mean gradient had gone up to about 30. And so when we think about aortic stenosis, as it says, it's very different. We're thinking more about an issue with oxygen supply demand. And obviously, aortic stenosis is going to limit that supply. And when you're an athlete, you're increasing the demand. And we do know, I'm not going to read through all the mechanisms here of coronary flow disruption in aortic stenosis, but I'll summarize it by saying that even in the absence of coronary disease, aortic stenosis does cause a reduction in myocardial blood flow and impaired coronary flow reserve. And so these people do get ischemic. And unlike aortic regurgitation, we do see athletes dropping dead from aortic stenosis. In all these data sets, about 3 to 5% of sudden deaths in young athletes is related to aortic stenosis through this mechanism. And so when I reviewed this data with him, clearly his stress ECG was significantly abnormal, deep ST depression with ventricular ectopy there. And actually, when you talked to him and told him all of this, he kind of said, well, yeah, I am getting a little bit of chest discomfort with exercise. And so essentially for him, strongly advised him not to play competitive sports and referred him for an AVR. And essentially, again, these are more just having the slide deck from the guidelines, and these are consistent with that. We need to be more conservative with aortic stenosis. So unlike aortic regurgitation, it is generally not well tolerated in athletes. For stage C, if they're asymptomatic, this is a progressive disease. It's unlike aortic regurgitation, again, where they can stay with the same amount of aortic regurgitation for years and years. Aortic stenosis is only going in one way. It's only going to get worse. If they're already severe aortic stenosis, even if they say they're asymptomatic, if they want to compete at elite levels, at very high levels, I think they should just go for surgery. Stage B then is really a spectrum. I mean, all the way from mild to moderate aortic stenosis, all the way up to moderately severe aortic stenosis. And those individuals have to be, their advice has to be individualized, but really I rely heavily on maximum volition stress testing to make sure that we're seeing absolutely no evidence of ischemia on those testing. So I'm a little hesitant to talk about aortic dilation at Yale, where we've got so many world experts in aortic dilation. So forgive my hubris in talking on this topic. But again, this kind of fits hand in hand with bicuspid aortic valve, and we have to, this comes up a lot. So this is a 22-year-old, 6'4", 250-pound college football player. Screening ECG and echo shows during screening, a murmur is heard. He's got a bicuspid aortic valve, so his further testing is done. He's got a 4.2 mid-ascending aorta, and of course, the only question he has is, Doc, can I play? And so this is a common question, again, that comes up in clinic all the time. And so, I think it's important to recognize that aortopathy in bicuspid valve is related to a couple of different factors. It's probably a combination of both genetic abnormalities at a cellular level in the aorta and also hemodynamic factors, and because we can see this come on even in infancy. And so it's common in the general population. 20 to 30% will have aortic root dilation during their life at the root. 60 to 80% will have mid-ascending aorta. And really the population we're talking about, which is the young athlete, the collegiate athlete, 7 to 15% of these will have aortic dilation depending on what data set you look at. I think before we go on, it's important to recognize the first step in this is to make sure that this aortopathy with bicuspid aortic valve disease is not a hereditary problem. This is not something like Turner's or Loeys-Dietz, because that's a totally different conversation. Those individuals are much higher risk. I think that that's the kind of first step that we have to do in evaluation to make sure that they don't have any of those conditions. And based on your history and physical examination, you may decide to do genetic testing. So we're not talking about those individuals. For other individuals then with a bicuspid aortic valve, we've got different kind of types of bicuspid aortic valve, aortopathy, I should say. And that's often associated with different fusion of the commissures. But the one we're kind of most concerned about is the type 3. This is the one that occurs in younger men and primarily affects the aortic root. Again, if we've got an athlete who comes in to us and they've been diagnosed with a dilated aorta, we need to understand what is expected for that particular athlete. So we need to understand what is a normal aortic size in the athletic population. So we already talked about the fact that athletic heart can affect the ECG, can affect chamber sizes, but what about the aorta? And so it would make sense that it can be affected. I mean, the hallmark of our evaluation and treatment in patients who have a dilated aorta is management of blood pressure. We know hypertension accelerates the disease, and we're really focusing on managing this. And so what happens when we exercise? Again, if we're looking at aerobic exercise, we're seeing this massive increase in cardiac output. And with that, we do increase our blood pressure. We see a prolonged increase in blood pressure. When we look at resistance training, it's a different stress. We get these short bursts of increased blood pressure. This was a study where they did intra-aortic pressure monitoring when someone was doing a double leg raise to maximum. We can see the systolic blood pressure getting up to 400 millimeters of mercury there. And so athletes are exposing their cardiovascular system to these big hemodynamic stresses. Does the aorta adapt? And so there are data around this. This was a meta-analysis looking at elite athletes, and it does show that the aorta is bigger in young athletes, we're talking about collegiate athletes here, than controls, 3.2 millimeters at the sinus of Valsalva, but it generally still falls within the normal range for most individuals. And we didn't see any difference between strength and endurance athletes. Now, there are a lot of other data sets that have come out since that, and essentially they've consistently shown a similar story. In men, we'll see an aorta greater than 4 centimeters in about 1 to 2% of the population. In women, about 1 to 1.5% will have an aorta of greater than 4.3. There are some other things that we have to factor into this. And again, we talked about size when we're talking about LV size, the actual size of the individual. This is from the WAIS trial or the WAIS study where they looked at different heights. And obviously, the taller you are, the bigger your aorta is. And the older you are, the bigger your aorta is. And again, this was borne out in the same NBA data set where the bigger the athlete is, the bigger the aorta. Now, there is a kind of plateau you'll see here, so at the extremes of size. So even in that population, and this was something that we used to do, you have a 7-foot athlete come in and they had an aorta of 4.5. A lot of times people used to say, well, that's just normal for a 7-foot athlete. It's not. It's abnormal for those athletes. Only 5% had an aorta greater than 4, and very rare to have a aorta greater than 4.2 in this cohort. Now, the aorta does definitely get bigger as we get older. This was data we looked at in the NFL. So we did screening of 500 retired NFL athletes, and we can see that the aorta is skewed to the right here in terms of size. If you compare this to an age and size match control in the Dallas Heart study. This was a study done by Timothy Churchill in Mass General, looking at runners and rowers in males and females. And again, they've gotten the actual versus the expected in the darker color, actual size aorta here. So definitely we see the aorta is getting bigger in older athletes. For today, the big question is, well, what about the bicuspid aortic patient, right? So we actually, in the past few months, there's been published 2 big data sets looking at the impact of exercise on bicuspid aortopathy progression. One of these was from a Dutch group here where they looked at over 400 patients with a bicuspid aortic valve, and they divided them into 3 groups based on their lifetime exercise exposure. And so in the highest group where you measure the amount of exercise they did per week, did over 1,000 MET minutes per week, versus the middle group, 500 to 1,000, versus the lower group, less than 500. And the reality is that we didn't really see any difference. There didn't seem to be in the bicuspid population a signal that exercising for a long time throughout your life actually accelerated the progression of your aortopathy. This was the other trial that looked at this, the SPREAD multi-center international project, and they looked at bicuspid valves, athletes with bicuspid aortopathy versus athletes with a tricuspid aortic valve versus non-athletes with bicuspid valve. And essentially what they showed was the athletes with bicuspid valve were the same size as the non-athletes with a bicuspid valve. And they were both bigger than the tricuspid leaflet. So again, the message here is not seeing an acceleration and progression of aortopathy if you exercise a lot. But the big question really comes down to dissection, right? That's what we're worried about. Are they going to dissect when they're exercising? And we know that dissection occurs 5 to 10 times more commonly in patients with a bicuspid aortic valve than a tricuspid aortic valve. But again, the incidence is still very low. The incidence is low for both. So in under 40 population, it only occurs in about 0.4 per 100,000 people. This is the general population, not an athletic population. If you look at, again, a general population, we see that if you don't have significant valve disease, your life expectancy is essentially the same. So it's not like we used to be worried about the bicuspid aortic valves, and we used to say we had to operate on them earlier like we did with Marfan and we did with Loeys-Dietz, but those guidelines have changed. And essentially, they're considered a similar type of risk to a tricuspid valve, and the surgical guidelines reflect that. To come back to the younger population, though, when they're dissecting, is it because they've got bicuspid aortic valve? And I think the IRAD data is probably the best data in this regard. And so here, I'll just highlight, most of the patients that dissected, 50% of them actually had Marfan. So under 40, if you dissect, you have a 50% chance that it's Marfan that's driving it, versus bicuspid valve, which was 9%. So under 40, it's not common for you to get a dissection. It's very rare to get a dissection from a bicuspid valve. But the question is, do these natural history data apply to athletes? And what is the dissection rate or risk in athletes? So we go back to these data sets that we looked at earlier here, and we can see in the US registry, about 4% of athletes died from aortic rupture. And in the NCAA, it was about the same, 3 to 4% of athletes died from aortic rupture. So if we do the numbers here, just back of a napkin kind of numbers, right? So how many athletes are participating in active competitive sports in the US right now? So about 8 million is the estimated number. Now, if we say that 1 to 2% of those individuals are going to have a bicuspid valve, up to 160,000 athletes are participating in the US with a bicuspid aortic valve. And if we say the aortopathy risk in under 40 is up to 15%, it means we've got somewhere between 6,000 to 25,000 athletes with bicuspid aortic valve who have aortopathy that are participating. And then the risk of dissection in all athletes is somewhere between 0.25 and 1 per year. And then we remember that most of those are related to Marfan syndrome. So about 10% related to athletes. The bottom line that I'm trying to make here is there's a lot of people with a bicuspid valve that have aortopathy, and the rate of dissection is extremely rare. Unfortunately, again, to make this even more complicated, size is not a great predictor of risk. This was a study from from Yale actually, where they looked at dissection in multiple, what people were doing at the time. And this, you can see that some of these aortas were like 3 centimeters, 4 centimeters. The IRA data would suggest that 40% of dissections occur in aortas that are less than 5 centimeters. So size, again, is not the best predictor. So what do we recommend from sporting participation? Well, the last guidelines we have come from 2015, and they're pretty conservative. So if we look at a bicuspid aortic valve here, if men are basically in any way dilated, we're making some restrictions. So we're telling them they can only participate in some sports, they should avoid collision, they should avoid weight training, a really total absence of data to support any of these recommendations. If they're greater than 45 millimeters, avoid all competitive sports. Now, my feeling, and many in the field, including the people who wrote these guidelines, have felt that these are way overly restrictive. And we are going to be publishing next month or the month after, Rachel. We're doing an update to these guidelines. And I had the honor of chairing the task force looking at aortopathy and aortic valve disease in this. Unfortunately, I can't tell you what they're going to say, but you will see that there's going to be some significant changes compared to the prior. But there's definitely going to be some people that are high risk, and we are ultimately going to have some conversations with people. Look, this is probably not a good idea, or they themselves will say, look, I don't want to take this risk on. I don't want to continue to compete, but what can I do? And so this is a conversation that I think we need to be equipped to answer. And I think I always begin by recognizing all the benefits of exercise, particularly in the context of aortopathy. We see people who exercise, but primarily moderate aerobic exercise, moderate intensity, regular aerobic exercise, lower blood pressure, lower systemic vascular resistance, improved autonomic control, decreased sympathetic adrenergic drive, improved endothelial function, lots of different benefits. And this has been shown in humans and animal models. You know, if you look at animal models of Marfan syndrome, those animal models that run and exercise regularly actually have much healthier aortas than those who don't. So I think it's important to first recognize these benefits and talk about and give them a prescription in that regard. Now, we also have to factor in the hemodynamic effects of different types of exercise. And so I had a clinic where I had a little old lady come into me with an aorta that was enlarged, followed by an NFL linebacker who came in with an aorta enlarged. Both of the aortas were the same size, and both of them were told not to lift more than 50 pounds. And so that is just crazy. And so I think you got to factor in, you know, the underlying strength of the individual when we're trying to give recommendations. And so I would highly recommend that we never give weight restrictions, that we never say don't lift more than X or Y. Some people say 30 pounds, 50 pounds, whatever. It makes no sense for this reason I've just pointed out. And this has been shown in data. This is actually looking at blood pressure response to people lifting, I think it's 300 kilograms. Sorry, the writing is too small here, but doing 10 reps. And this person actually has bigger thighs. They're a stronger individual, and the blood pressure response is lower than this person who's lifting significantly less. So again, our underlying strength is going to impact our hemodynamic response. Oh, sorry, I think I hit end of talk there. Apologies. So then the other thing we should think about is the percentage maximum voluntary contraction. How hard are you working to lift this particular weight? Because that actually impacts it as well. If you're using 50% versus 87%, as is in this example, again, your blood pressure response is very different depending on, you know, how hard you are finding lifting doing the weight. It also depends on what maneuver you're doing. This is why I really think saying don't lift 30 pounds makes absolutely no sense, because if you're talking about squatting 30 pounds, it's very different than doing a lateral raise of 30 pounds. And again, that's going to impact your hemodynamic response to that. Valsalva is interesting. Valsalva certainly causes a significant spike in blood pressure, but particularly for the bicuspid population where we're really worried about the ascending aorta, it also increases the intrathoracic pressure. So the transluminal pressure actually is probably minimal during that, not probably, it is minimal during that Valsalva maneuver. So Dr. Ben Levine and UT Southwestern and others were looking at doing some research on this. Can you actually guide someone to do an effective Valsalva to minimize the transluminal pressure? And so there's work being done on this to try and figure it out. The concern is that, you know, you may be balancing it during the early phase of the Valsalva, but you do get a rebound in blood pressure when you release it. So more to be figured out on this. But Valsalva, essentially, in my mind, if you have to grunt to lift something and you've got significantly dilated aorta, it's probably too heavy. And then the last thing is lifting to fatigue. So if you're, and I always talk about this, if you're lifting and you get to the point where you've got the last weight, that's where we see the real big spike in blood pressure. You can see the blood pressure going up here as this person lifts to fatigue. So we always want to try and leave something in the tank as we're exercising. So essentially, I think when we're talking to people about not competing, but safe exercise, I try and focus on aerobic exercise, doing regular moderate exercise, and then doing some resistance training, but try and keeping it in a low intensity range. So what do we do with this guy? Doc, can I play by the guidelines? The answer is no. For me, it was yes, but we need to do one step at a time. Obviously, we have to make sure he doesn't have any of the hereditary thoracic aortic aneurysm issues that we talked about earlier. And then we have to talk about the knowns and unknowns. So we have to go through a shared decision-making process. But really, and Rachel talks more eloquently than anyone about this, but really we have to think about shared decision-making for these athletes, because, you know, if you look at these individuals, who are we talking about being greater risk of death? Is it this athlete that has a mildly dilated aorta, or these other individuals here? And the reality is that we're facing, you can see over time, America is going on fire. This is basically looking at BMI, looking at diabetes over time. And so the population is kind of going in the wrong direction here. And so we have to recognize the benefits of it. Not only from cardiologists, we think about the cardiovascular benefits of exercise all the time, but really we have to think about outside of this. What are the mental, emotional, social benefits of exercise? And so, you know, is it okay to deny these benefits to young adolescents with borderline disease, where we just want to feel more comfortable when we're giving them advice? So this is where shared decision-making comes in, and these are the kind of pillars of shared decision-making that I won't read through here, but I think it's key to what we do in sports cardiology. And again, I think Rachel has really led the way on this. So in summary, for athletes with aortopathy, it's really important to remember that dilation is common in this population. Dissection-related deaths in athletes is very rare. When it does happen, it's usually related to Marfan's. There are cases of bicuspid aortic valves dissecting and dying. I mean, it's not that it never happens, and that's where the shared decision-making comes into it. We do now have reasonably good data to show that sports participation does not accelerate disease process. Size is not a very good predictor of risk, and so we've really got limited data to guide these individuals. And so we really do need to lean on shared decision-making and regular surveillance for these dilated aortas. And finally, for those who decide not to compete, I think it's important that we do give them some sort of exercise prescription to give them guidance about what exercise they can do. But unfortunately, this talk has probably been different to certainly other Grand Rounds talks that I give and other talks that you guys have probably heard, because a lot of other talks is based on data, right? That's what we work in cardiology world. We work in randomized control trials. And unfortunately in sports cardiology, we just don't have that data. And so we got to try and piece all of these other pieces of information together to try and come to some rational reason for why we're giving guidance to athletes to do or not do what they want to do. But we do want to gather this data. And one of the ways we're doing this is the outcomes registry for cardiac conditions in athletes that Rachel is also an investigator on. I'm sure you're all aware of it. But this is a international now registry of young athletes who have cardiac conditions. And hopefully over the years, if we can continue to input all of these patients into this and anyone can enroll, this is just online. You can use the QR code. I'm sure if you let Rachel know, she'll be able to enroll these people. But I'd encourage anyone who does have an athlete with bicuspid aortic valve or aortopathy or really any cardiac condition to enroll in this. So in years to come, we'll be able to actually give more scientific guidance for these questions. And with that, I'll stop and take any questions. Thank you.
So a two-part question, and it's sort of based off a little of our conversations earlier. And I know it's a hard question to answer, but there are no surgeons in the audience, so we're good for now. So when you do need to refer these patients, right? You've practiced at some impressive places where physicians can do all sorts of things, and you're also dealing with, athletes who have resources to go. And we're in a place where we have our surgeons here, we had surgeons here who were doing the Osaki procedure and that we've had folks who want to repair it. There's a local surgeon who's experienced in Ross, and then there are surgeons who can put in aortic valves. And if you want me to put a TAVR in the patients, I'd be happy to do that. But I'd be
Even
curious.
with aortic regurgitation?
Yeah, we have those now.
Okay.
We have them now. But I'd be curious sort of when you have that, how you're approaching the different surgical procedures that are on. You mentioned, right, none of them are perfect, but what's your thought process?
Yeah. So, if the various options we have, as you've kind of gone through, is aortic valve replacement. To be honest, I think that putting in a mechanical valve in a young person and they have to be on warfarin for the rest of their life, I just wouldn't. I'd never do that. I try to avoid it, even though that's the kind of first step for most. I think particularly for this population, I just try and avoid that. Obviously, a tissue valve is, facing multiple operations throughout their life. Thankfully, most of these athletes are like those cases that we showed where they just have prolapse of one of the leaflets. And for me, I've sent people for Ross, for Ozaki, for all of these. But I think the repair, it's usually the simplest option and the simplest surgery is the right one. And so for a repair, as you know, it's a pretty simple operation. They just kind of tighten up the commissures for the valve. Essentially, none of them are ideal. Depending on what data set you look at, you're going to have somewhere between 90 and 95% at 10 years are still working well, which is good. But, for someone who's 24, I ideally would like to have a better option than that. The Ozaki was something, I don't know, you guys are doing that as well.
We have not anymore, right?
Okay.
It's very surgeon dependent.
Yeah. I mean, it's basically where you're using the pericardium to actually create an aortic valve. And I mean, it's a remarkable operation. When you do imaging after that, you cannot tell that person had any operation done at all. I mean, the valve just looks like a native valve. But like you've pointed out, the outcomes are also, first of all, we don't have very long outcome data apart from Japan, which are very good, but it seems to be very operator dependent as well. So Justa Pedersen was a surgeon at Cleveland Clinic who used to do that. And I sent a few of my athletes to him and had remarkably good outcomes with them, but he's retired. And so like here, now we don't have anyone kind of doing that. And I know that they've kind of, because others have had poor outcomes, people have gone away from it.
Can I ask one just follow up? What do you tell the patient, assuming they're not playing hockey or football, so they're, it's a non-contact, about what they can expect going back after surgery? Yeah.
So I think that's after the post-operative period. So I tell them they need to, the biggest concern I have is the sternotomy. And so I've often had, particularly if they're hockey players or they're players that are taking trauma to the chest, I'll talk to the surgeons, and oftentimes we'll put plates in to help with sternotomy healing. And I've never had any adverse effects from doing that. There can be, I mean, they can get infected, but I've never had that. So I think a lot about the sternal wall healing, and I basically tell the athlete themselves that they need to wrap themselves in cotton wool for 6 weeks. I mean, they just can't. They got it walking only. They got to let the sternum heal. They got to not exercise vigorously during that period of time. The other thing that I have, and there's not a lot of good data around this, and this is solely my own practice, so that's my disclaimer here. But I've had a number of elite athletes get pericarditis after open heart surgery. They seem to get more and I think it's because they're returning to exercise early and vigorous exercise early. So I have the last few I've sent to surgery, I've put them on colchicine. And I haven't had any issues with it. I mean, it's pretty benign. I might get some diarrhea, I back off, but that's pretty much it. But I've had a number of athletes, and it's not like there's piles of young elite athletes going for open heart surgery, right? I don't want to give that impression. But the ones I've had just way too many of them with big pericardial effusions, needing drainage, with pericarditis, and some of them have had to retire as a result of that, or have had long-term issues as a result of that. And in my mind, colchicine is pretty benign, so I've started doing that.
That was a wonderful talk. Puts a lot of these difficult issues into perspective that we haven't heard before. I was really impressed by the reverse remodeling that occurs in AR after detraining. And so, part A of the question is, what is that? I mean, what is the remodeling? I'm sure it's not hyperplasia, because those cells wouldn't go away. So there's a hypertrophic response that then sort of the cell at the cellular level shrinks back to a normal size. I mean, what is that reverse remodeling? And is there any way to predict that will occur besides having the athlete stopping their training? I mean, we used to see if there's augmentation and contractility with exercise, but I'm sure all these people augment their contractility with exercise. So
Yeah.
So
Again, I think the larger part that we're seeing is a reduction in cavity size for these individuals, and that's all just flow related. As to what's happening at a cellular level, I'd love to hear other people's thoughts on that. I don't think we have information on that, because we haven't done biopsies on these pre and post. But I think it is just a reduction in size of the myocytes. I mean, essentially, and cell number. In terms of being able to predict who's going to reverse remodel, I think it comes down to what kind of training they're doing and what volume of training they're doing. I mean, if it's someone that's doing 2 hours a week and they've got a big LV, dilated LV, stopping 2 hours a week, they're not going to remodel. If they're doing 15 hours a week of high intensity, that's different. They're probably going to remodel. But I think your question more gets to, is there an imaging parameter that is going to get to that? And, the one thing that has been looked at is global longitudinal strain in that regard. And so looking at strain, lower global longitudinal strain predicts a lesser likelihood of appropriate remodeling post-surgery. So that's one thing that we certainly will look at. Yeah. Thank you.
So we now have radio tracers that can look at fibroblast activation protein or activation of fibroblasts. And that's been used in the post-infarct setting, where they're in the early insult is rapid, activation of fibroblasts, which then sort of goes down. But in some of those patients, they have persistent proteolytic activity out beyond 2 years. And these agents are now being applied in pulmonary hypertension, aortic stenosis. And so it may be a way to sort of guide sort of the state of sort of the remodeling or gain an understanding of what's going on with reverse remodeling.
So it's a great point. And I think one of the things that we do when we're trying to differentiate between athletic remodeling versus pathologic remodeling is also look at T1 mapping, right? So on, obviously in CMR, we can tell if there's an expansion of the extracellular matrix based on T1. And so that's not what we see in athletes. So if you're looking at kind of the patient who's got an LV wall of 13 millimeters and you're trying to figure out, is this HCM versus athletic remodeling, those T1 curves splay completely. So obviously the HCM have expansion of the extracellular matrix. The athletes do not. So this is all, myocyte hypertrophy as opposed to expansion of the extracellular matrix.
Thank you very much, Damon. That was excellent presentation. So just have a quick question. So as you rightly said, size is a weak predictor of dissection for aortic dilatation. But the current guidelines are still mostly based on size, and these are based on old data. So are there imaging biomarkers out there that we should be looking at that can be a better predictor of dissection?
Yeah.
For instance, some people have looked at eccentricity of the jet or the shear stress effect of the jets. So what's your opinion about this and any other biomarkers that we should be looking at?
Yeah, it's a really great question. And Eric Isselbacher actually came down to Sanger just recently, a couple of weeks ago, and gave a talk on aortopathy. And, one of the questions, very similar question, was posed to him. Those guidelines actually were very specific. I mean, they stuck to linear dimensions, the 2020 aortic ACC guidelines I'm talking about. They really stuck to linear dimensions. They comment on indexing for size and stuff like that, but most of the recommendations in terms of surgery was based on linear dimensions. And they didn't even index it for gender. They just said, if you're above 5, if you're above 5.5, they just use that. And the reason just comes down to the data, the outcome data. It's all the outcome data is based on linear dimensions. And so I think the best other outcome data is based on area to height index, but that's primarily or actually exclusively from Cleveland Clinic. And so again, it's a very different patient population. The outcomes are based on surgical outcomes from Cleveland Clinic in that context. So it all comes down to outcome data. It would be phenomenal to be able to do that. I mean, when you go in, as you know, you talk to the surgeons. When the surgeons replace these aortas, they come out of the OR and go, man, that was paper thin. That was going to go anytime. Other times they come out and go, that was never going to rip. I mean, that aorta felt as hard as a rock, or as healthy. I shouldn't say as hard as rock, a very healthy aorta. And I think that-that's the holy grail, right? How do we get our imaging to the level that is comparable to the surgeon's hands when they go in there? And we're not there. And I think a lot of the stuff that you've mentioned there, pulse wave velocity, a lot of the stuff that we're doing on MRI, on looking at extracellular matrix, on strain, on all of these things are all under investigation right now. And hopefully we will get to the point where we've got both resolution from our imaging and functional data that will be good enough to be able to predict those aortas that are very thin. I don't think we're going to get there to the point where we're able to say this one is going to dissect or not, because dissection is so rare, right? But at least we'd be able to kind of say, and Eric Roselli is doing this work at Cleveland Clinic where they're looking at the tensile strength of the aorta that they remove. So you take out the aorta, you look at the tensile strength, what is a strong aorta and what isn't, and then you go backwards and you look at all the imaging and say, okay, well, what were the predictors of those aortas that were weak versus those ones that were strong? But nothing reliable has been identified to date. But I think if you can come up with that, Emmanuel, be a rich man.
I was kind of struck by the slide you showed. It was like the older data set that showed, what people were doing when they had their
Yeah.
dissections. I mean, it was a lot of them were weightlifting and
Yeah.
and stuff like that. But it seems to be somewhat of a disconnect between, I mean, it seems like okay at, smaller sizes and okay to participate in athletics, but there's still weight restrictions and stuff, lift in terms of lifting and stuff. It seems to be a bit of a disconnect. I mean, what if in certain sports, there would obviously be large, exertions and stuff. I don't know. I just kind of saw that.
No, I think it's a fair comment. That case series, the point they were making was that people who are lifting can dissect, right? So it was a very, that was what they were showing in that. So there are other observational data looking at what people are doing at the time of dissection. And there certainly is a signal that when you're doing, for some people that when they're doing extremes of weight resistance training, that they may be at higher risk at that time, but not always. And nothing is always. In fact, most of the time it's not that. One of the highest risk sports in one of the largest series was playing golf. And so, it's impossible for us to be overly prescriptive on, very small numbers in these data sets, I think. But I do think it's, when I do spend time explaining the hemodynamics of different stress, of different exercise, I should say, and recognizing, if you're doing 1, 2, 3 rep maxes, you're spiking your blood pressure to 400 when you're doing that versus you're going for a cycle or a run or whatever. It's going nowhere near those kind of ranges. And so I think explaining that to patients, not necessarily the elite athletes, because they kind of have to do what they have to do if they're going to play, but more for the older individual with, aortopathy that wants some guidance on that. Spend some time talking through that, because like even last week I had a lady who used to be a long distance runner, found out she had an aortopathy and started weightlifting instead. And so I kind of said, look, do the opposite, go back. So I think just having that discussion with people can help.
Thanks.
Thank you, Dermot, so much. It was a wonderful talk, and I think we're over time. If other people have questions on that.
Thank you. What I should have done was send you my slides to make sure that that was what you were looking for, Rachel.
It absolutely was perfect, yeah. It was funny, too, because I invited you to bring this up to fill this sugar out. There was, it was an arrhythmia person. I'm like,
Yeah.
No, that was absolutely wonderful.
Yeah. Oh, good. Thank you. Thank you.
This is also Noosa.
Yes, I'm sorry.
And so, there are.
Yeah, I think. I don't know of any data that shows that, how they correlate with things on strength or regarding that.
Is that data that you want to sort of acquire? How is that, why you're bringing that up, that it would be a good study?
Yeah, I mean, so unfortunately, some of these agents are not FDA approved, right? So Mayron and myself are trying to do it, but if some of the first,